Welcome everybody to this podcast on when are a drug-coating balloon useful in CTO treatment. I'm Roberto Garbo, interventional cardiologist and director of CTO and complex PCI program at Maria Pia Hospital, Turin, Italy. And I have real pleasure to have with me Pier Francesco Agostoni, interventional cardiologist from Antwerp, Belgium, and a great CTO expert. Let me ask to Pier Francesco, can you tell us some introductory notion about the concept of drug-coating balloon in PCI?
Thank you very much, Roberto. Big pleasure to be here. And I would like to start, before speaking about drug-eluting balloon in details, I would like to start speaking about POBA, poor old balloon angioplasty, because when we use drug-eluting balloons, we make a step back in a certain way. We go back to the POBA era. And if we look at this chart, when we consider POBA restenosis, we know that POBA restenosis has some peculiar characteristics that make it different than classical in-stent restenosis. And specifically, after dilating a vessel with the balloon, we obtain some enlargement of the vessel, some micro dissections of the plaque. And once we release the balloon and we retract the balloon and we control, several phenomena can happen. One phenomenon occurs pretty early after the balloon, and it's called elastic recoil, and it's just a recoil of the vessel wall that tends to become smaller again pretty soon, and that happens in the first hour after our balloon. And then two phenomena occurs in the long term, between 1 and 6 months, and one is the negative remodeling that is similar to a shrinkage of a scar in our tissue. So the vessel gets smaller progressively due to this shrinkage phenomenon. And then we have the classical neointimal formation that is well known after stents. If we look at the percentage of the each phenomenon impacting the total restenosis effect after POBA, we see that the majority of the restenosis is driven by recoil and negative remodeling, and that is about 70%. Meanwhile, neointimal hyperplasia after POBA is only 30%, and that is a major difference between restenosis occurring after POBA versus restenosis in stent. When we move to a drug-coated balloon, we know that the drug-coated balloon is just a balloon, so it has the same concept as the balloon that I just mentioned, however has drug on top of it. This drug is usually mixed with an excipient to keep the drug at the level of the balloon, and once we inflate the balloon, the drug is released. The inflation time usually is about 1 minute, and during this minute the drug is released from the balloon to the vessel wall. Of course, we need highly lipophilic drugs, and typically paclitaxel is the most common one used. And we know that by inflating 1 minute a balloon against the vessel wall, this is from animal studies, paclitaxel remains in the vessel wall up to 6 months after the delivery. So in very short time, you can really achieve high dose of paclitaxel in the vessel wall for a long term. When we speak about a strategy, when we use only drug-coated balloon to treat stenosis in the coronary vessels, it's crucial to remember that the first step is a proper lesion preparation, is an optimal lesion preparation. And that means that we need to pre-dilate our vessel with balloons matched one-on-one to the size of the artery, and we need to obtain a good result, or let's say at least a reasonable result, with substantially no severe residual stenosis, and most importantly without flow limiting dissections. So only once we achieve this phenomena, we can proceed to the delivery of the drug by means of the drug-coated balloon. So the drug-coated balloon has to be seen as a device to bring the drug in place and not as a device to open up the artery. In case we do not achieve this acceptable angiographic result, we should consider, of course, implanting a stent. So if we go back again to the chart of the POBA and the restenotic effect after POBA, we can say that drug-eluting balloon nowadays work in a different way respect to stent. We know that stent works mainly on the elastic recoil that is seen pretty early after POBA and on the negative remodeling, but on the other hand pays a bit more the price of the neointimal formation. Of course, DES improved that massively, but still sometimes it occurs. On the other hand, DCB, drug-coated balloons, help mainly in reducing the negative remodeling, probably because the drug, paclitaxel, blocks some phenomena that occurs for the shrinkage of the vessel, and of course they also block new intimal formation. So this is crucial to remember when we think about drug-coated balloon in coronary arteries.
Thank you, Per Francesco. I think that was great, your explanation of the concept of reducing negative remodeling with drug-coated balloon. I think it's a really modern approach to PCI. We know that in the last year, we tried to find a solution with the scaffolding to reduce the metal in our artery. And I think that we treat more complex patients with more diffuse disease. I think that we need to really to think about an evolution of our job using more and more drug coating balloon. What do you think about? Do you believe there's a space even in CTO PCI for that?
It's a very good question, and I don't think I have a total answer, but I can raise some points. First of all, let's focus a bit on CTO-PCI in general. We know that usually is accompanied by much longer stented segments. It involves in several times subintimal passage, so we are not intraplaque, but we are extraplaque or even subintimal. Is much more commonly faced with severe calcification. And we also know that the long term of CTO PCI is poorer than normal PCI. So in that sense, the idea to maximize the effect of our acute treatment to obtain a durable result is crucial in CTO PCI even more than in regular PCI. And inside this, DCB could be an option for in several situations. And let me just give an idea of the potential advantages of DCB. First of all, as you mentioned before, we could indeed use less metal, and the current hype is leave nothing behind. So we just deliver the drug works, and then is dissolved, and we don't leave any metal behind. So that's definitely very, very interesting. One technical advantage of DCB is because there is no metal on the balloon, it could be also more trackable in more complex anatomy, so you can reach more distal vessel without having major problems as when you have to bring down the stent in the distal vessel. Another interesting advantage is the fact that DCB allow less fear once you try to treat bifurcation, because you are less afraid of occluding side branches that occur more frequently when you implant a stent. It's definitely a very interesting option in those CTO where you have the CTO itself and very long disease segments downstream the CTO, where there are two things that we don't like. First of all, we don't like to stent that long, and second thing is also a sizing issue, because we know that these vessels below the downstream the CTO are underperfused, and when we put a stent there, we know that in the long term the stent can be largely undersized. So having a tool like a DCB that allow only to spread the drug and then let the vessel remodel and grow just by restoring the flow is a very interesting tool. And one extra interesting option is definitely in the subset of CTO that are called the instant occlusions, because there we already have the scaffolding of the old stent that got occluded, and we also avoid what is called the onion effect of adding stent in stent. So that is definitely another very interesting situation where DCB could be advantageous over classical stents. And one last advantage of DCB in this setting is also the potential need for a longer double antiplatelet therapy. So we can consider to reduce the antithrombotic regimens, at least the length of the antithrombotic regimen, because we don't leave metal behind in the coronary artery, and that allows indeed potentially to decrease the duration of the APT. On the other hand, we also have to mention the disadvantage of DCB. First of all, the crucial role of proper pre-dilatation is fundamental in order to deliver the DCB. So if we do not obtain this perfect result after pre-dilatation, meaning no major dissection and optimal power result, we cannot go further with DCB and we have to switch to stent. It's most probably, I would say almost for sure, not suitable when we use subintimal or restor plaque techniques in CTO, because in that case we deform so much the CTO, the vessel, that probably we need absolute scaffold, a metal scaffold to keep the vessel open. The third point is that the long-term equipoise data between DCB and DES are still debated, so we definitely need more data to prove the advantages of DCB versus stent. And I think the last point, and it's probably the most important, is that there is a major mindset change for the interventional cardiologists, mainly for the younger generation, because you need, when you work with DCB, to accept less good result as the one that you achieve with stenting, and you have to let the drug work. Most of the time when you deliver DCB you have a reasonable result, but it's not as good as stenting, and then if you control it at long term you have a very good result. So the drug works with time, the remodeling of the vessel works with time, you even have vessel enlargement after DCB, but this is something that the current generation of interventional cardiology is not used with. So that's a major mindset that is a potential disadvantage, because we have to work on the culture of performing PCI without stents.
Yeah, thank you, Per Francesco. I like very much your explanation, because I think that mainly the concept that when you have side branch bifurcation, the patency is essential, and DCB can help you a lot. When you are, we deal with diffuse disease, we have long CTO, long disease distal to the CTO, with the underperfused vessel, and if we go to stent during the procedure, then we can have a malposition, because then the vessel can grow a lot, and this is a main concept which we need to, if the more we use metal, the more we can have a problem at the follow-up. So this is a very important point. In stent occlusion, it's clear that we need to avoid metal over metal. And then very interesting what you explained about the mindset. So we need to change our mindset. We need to think that we don't need to obtain like autobahn in the artery, but we need to think about the future of the patient, and this can be really interesting. And if we are able to use imaging, we can understand that this is the future of our procedure. So. Can you explain? Do you have some case in which you can explain your idea of DCB in CTO PCI?
Sure. Let me show you indeed a case that can summarize a bit what we just mentioned. And this is a case of a woman who has a CTO of the right coronary artery, and this is an in-stent occlusion. And we can see here on the left side the occlusion of the right is in the mid segment of the right, and we have on the right the collaterals coming from the left system, and we see a very large territory supplied by the occluded right. So definitely worthwhile to open this vessel. If we speak in terms of occlusion length, we can see that the occlusion is relatively short, it's not that long, but there is a huge amount of disease either upstream and downstream the occlusion itself, and there is definitely some calcification. So we scored, in terms of JCTO score, this CTO with a JCTO score of 1. Wiring of the vessel was pretty easy. We crossed the lesion easily, and then we just ballooned the proximal and the mid part of the right, trying to stay away of the crux with the 2 compliant balloon and 2.5 non-compliant balloon, in order to obtain already a pretty good dilatation of the vessel itself. And then we could visualize the vessel antegradally with just antegrade injection, and we can see here that there is some disease at the level of the crux. At this point we just wired the PL in order to avoid losing this major vessel, and we dilated again at the level of the crux with a 2.5 non-compliant balloon. And this is on the right side the final result after proper pre-dilatation, and we have substantially a good flow. We have substantially no major dissection visibles, and we have definitely a less than 30% residual stenosis. So we thought, okay, we are in an instant situation. We should, in order to stent again this vessel, we should really start from the crux and go all the way up to the ostium. So it will be like 90 millimeter stent at least. So we decided to go for drug-eluting balloons, and we applied the first drug-eluting balloon at the level of the crux, coming backward, and it's a 2.530 millimeter balloon inflated for 60 seconds at 12 atmospheres, so time to release the paclitaxel in the vessel wall. And then a second drug-eluting balloon, and you see it on the right side, trio balloon by 40 millimeter, 60 seconds again inflated, and 14 atmospheres. And we got a good result of the segment that was treated with drug-eluting balloon. However, we have a dissection, residual dissection proximal to the old stent, and we see between the guiding catheter and the proximal edge of the proximal stent, we see clearly a dissection. And after this implantation in the proximal part, in the ostial part of the right, this is the final result, showing indeed a very good result, good patency of the vessel. The patient was doing fine 1 year after treatment, so we didn't do any angiographic control, but it was not clinically indicated, so we suppose that the vessel remained open. So let me underline the advantages of a DCB strategy in this specific case. First of all, small anatomy. Reference vessel diameter was about 2.5, and we know the stents in this setting perform less good than in larger anatomies. Definitely a very, very long lesion. Probably if we would go for stenting, we should have put 90 millimeter of stent. Despite the CTO itself was short, the vessel was totally diseased from the beginning to the end. Another interesting point was that there was already a scaffolding structure. There was the old stent that was present inside the vessel. Definitely distally, there was no clear landing zone in order to deploy a stent there. We were very close to the crux with a major risk also of side branch occlusion. This is the last advantage. So the presence of very large amount of side branches in the distal parts of the right, with the risk of occlusion of one of these branches in case of additional stenting. So I think that this concept that is getting more and more popular of an hybrid treatment where we treat with DES the proximal part of the vessel and we just use DCB in the distal part of the vessel is very interesting, either depending where the CTO is, of course, but considering treating mainly the CTO segment and the proximal part with DES and just distal to the CTO, or if the CTO is very distal, even the CTO with DCB is definitely a very, very interesting concept. It is spreading more and more in our field of interventional cardiologists. And here we have another chart with another case where they deployed a DS in the proximal part and they just treated the distal part with DCB to optimize the result.
Thank you, Per Francesco. Great case, very interesting. I need to tell you that 1 week ago I performed during a workshop 2 RCA CTO with diffuse disease in the distal vessel, and I performed drug-coating balloon in the distal right, and even a kissing drug-coating balloon with 2 Essential Pro at the level of the cracks in order to release at the same time drugs in both vessels. Do you have a similar case or not in your experience?
I've never done it myself, but I think I will have to do it soon. I think it's a very interesting concept. I think I mean there you really optimize also the spreading of the medication all over, so you really impregnate the whole bifurcation with drug, not leaving any space uncovered with the drug. So it's definitely a very, very interesting idea.
Yeah, we should do a study together mainly. Maybe it can be great. So I think that we can conclude this podcast. It was really, really interesting concept to have this innovative session on how to use drug-coating balloon in complex PCI and mainly in CTO. That are the most complex procedure we can have in coronary lesion. Thank you to Pier Francesco Agostoni for this great lecture, and I would like to thank iVascular for that they were able to sponsor this podcast. So thank you very much.
Thank you.
you.